Well, welcome back to It's a Brain Thing tonight, everyone. Tonight, I'm glad that you guys showed up. I was a little surprised actually to see folks out here tonight. The topic I figured would not be a big draw tonight, but what I decided to talk about is, in these talks I do a lot of speaking about the stigma that's associated with brain illnesses and mental health, mental illness and such. And the patients, and how the patients are stigmatized and the illnesses are stigmatized, but I haven't really mentioned a whole lot about the profession that treats the illnesses. And psychiatry is what we're going to talk about tonight. And there's several reasons for this. I think, just to give you a couple of little humorous stories, as being a psychiatrist, I have plenty of these humorous stories. But anytime I go into a social gathering and somebody finds out I'm a psychiatrist, the first thing that they ask, the first thing that they say is, "Oh, I guess I better watch what I say then." As if I'm just going to parties to work. So that's one thing. I think another time that it became clear to me that there's a lot of stigma about psychiatry is I went to a high school reunion, and unfortunately there was a gentleman there that I think he was probably high on some type of drugs or something, but he was so paranoid that he found out I was a psychiatrist, and he kept coming up to me. I wasn't even paying attention to him. I didn't really know him very well in high school anyway. So I was just visiting with my friends. He kept coming up and saying, "Oh man, you're analyzing me, I can tell, just looking at me, quit staring at me, And again, as if I was there to work. So, but he was pretty paranoid. And then, the other thing that struck me is, you see all these things, Tom Cruise, and you see all this stuff on the news about people not really understanding psychiatry and psychiatric illness. Well, I had the same kind of thing with the YouTube videos that I put out. I had one person comment from Canada, I don't know anything about them, but basically pretty extreme stuff about psychiatry, I won't use the curse word they put, but that the video was full of what, and that I must have been brainwashed by some guru, and that all psychiatry must die, so pretty extreme stuff. But it basically drove home all these things, drive home the message to me that people don't really understand the profession of psychiatry any more than they do the illnesses and the folks that have brain illnesses, which, by the way, can be any of us. And I don't think that the people that talk about these things realize that if they have a brain, they can suffer from these illnesses too. So they got to watch what they say. But I think, as you know, as we've talked about here before, we tend to stigmatize things we don't understand. And so if like throughout history, in the biblical days, epilepsy was felt to be possession by the devil. Now we know the science behind it. It's actually a part of the brain that's discharging when it shouldn't. There's too much electrical activity, which then sometimes spreads throughout the brain and can cause epilepsy or seizures. And schizophrenia used to be considered possession by the devil. I mean, in those days, they didn't realize why somebody would be walking around talking to themselves or talking to somebody that's not there. So that when they hallucinated, the patients would hallucinate or have paranoia or something. They figured again it was possession by the devil, and now we know better than that. So the idea is the more you learn, like for instance, as the science developed, then we started not to discriminate against epilepsy, and we still discriminate against schizophrenia, but we understand it better, and we're starting to get a little bit better about not doing so. I think that was sort of the goal of these talks, really, is I don't think anybody's really out there, or at least not too many people are out there talking about the brain and the current science of the brain. And so the goal of the talks was to get that knowledge out there with the goal of hopefully there being less stigma towards the illnesses and towards the folks that have the illnesses. But tonight, obviously, to also get rid of some of the stigma by increasing knowledge about the field of psychiatry and what psychiatrists do. In doing so, I'm kind of hoping that, in doing all this education and everything, I'm kind of hoping that people will number one, they'll not be as fearful to seek treatment if they need it. That hopefully the folks that need treatment, that these symptoms and things will be in sort of more understood, and people will figure these things out and pick up these things early enough that then people can get into treatment earlier. Which, like any other type of illness, the earlier you get treatment, the better with these things. And ultimately, I have a little grandiose idea behind these talks, is that if enough people see these things and learn about these things, that we might be a little bit better at paying attention to child development and how our kids are developing emotionally, because that will have an ultimate effect on society, I think. And I think that obviously isn't going to be just done by me, but if more people that have the knowledge or are out there spreading it, that would be a good thing. You know, there's still, the stigma is still there when it comes to these illnesses, when it comes to psychiatry. So I still routinely have patients say, you know, I didn't come in for a long time, doc. I thought about it, but I didn't want to come in because I thought it meant I was crazy. You know, I hear that every single day. Almost every patient tells me that. You know, there's also a big fear of what happens when they come to see me. What am I going to do? What am I going to say? Am I going to shrink their head? Whatever that means. And obviously the comments that people make, you know, about like for instance, I had in medical school, and this was another physician, believe it or not. I was doing transplant surgery, and this transplant staff physician, staff surgeon that was a transplant surgeon, asked me one day, "What kind of doctor do you want to be?" When I told him I would like to be a psychiatrist, he kind of chuckled and he said, "Well, why don't you become a real doctor?" So, you know, the stigma is even there amongst other doctors. You know, now he's probably not representative of all of the doctors. I think most other doctors have a better understanding of psychiatry and what we do. In his case, I sort of felt bad a little bit for his patients because he obviously had no clue about any of this stuff. And you know, transplant patients go through an awful lot. There's a lot of emotional things that would affect them. So tonight, you know, I've titled this talk "Psychiatry: The Science of Where the Mind and Body Meet," because that's kind of truly what psychiatry is, you know. And I guess the first thing right off the title, the first thing to discuss with you is what is a psychiatrist, what do we go through, and what kind of training do we have. And the first thing to realize is that beyond high school, okay, obviously we have to graduate high school. Once we get through high school, psychiatrists have to go through college, and that's 4 years. So usually 4 years of college. Through the college, you can major in anything you want. I had a friend who majored in history and still went on into medical school, okay? So you can major in anything you want, but you do have to have a bare minimum of science classes, you know, calculus, physics, chemistry, these things. And for my medical school, it was 90 hours, 90 credit hours that we had to have pre-medical classes. So, you know, so that's the first thing, is the 4 years of college. Once you get through the 4 years of college, you kind of have to have decent grades. I'm not going to say you have to have straight A's. You know, your GPA has to probably be at least a B average, I would say. I don't think you could get into medical school with just a C average, but a B average at least probably. You know, and then you have to do a college entrance exam. It's called the MCAT. And it's sort of like, you know, like when kids take SATs to get into college. This is sort of like the same thing, except it's all based on, it's a lot of science and other things. And again, your scores have to be pretty good on that. They don't have to be perfect, you know, but they have to be pretty good. So the combination of good grades, good scores on this test, and then an interview. You have to pass an interview, of course. So once you do all those things, then you are, if there's enough positions, you get accepted into a medical school. And a medical school then is 4 years after college. So I did 4 years at Purdue University, and then I did 4 years of medical school at Indiana University, believe it or not. I know that's quite a conflict there for a lot of people, but I'm still a Purdue fan at heart because the first 4 years was at Purdue. The first 2 years of medical school is kind of, it's similar to college, it's just more advanced. There's a lot, you're learning an awful lot of stuff, and it's all focused, of course, on the human body and physiology and all this. We actually have cadaver lab where we go in and do, dissect a human cadaver so we can learn all about the body and the brain and everything. So that kind of breaks up the classes a little bit. So those first 2 years, it's a lot of test taking in classrooms, sitting in classrooms like you guys are doing out there tonight. You listen and you take notes and all this, just like college but more advanced. After that first 2 years, you have to take a set of board exams, and that's kind of a big deal. Those things are really kind of tough to pass. Once you pass those board exams, you get to go on into your third and fourth year of medical school. Third and fourth year is not so much sitting there listening to lectures and all that. So you actually start going into the hospital, you rotate with residents and staff doctors, and you learn. You start to learn about all that. You rotate through all the different major areas of medicine. So you may spend 4 to 6 to 8 weeks doing surgery, doing OBGYN, doing family practice, internal medicine, pediatrics, all the different specialties, psychiatry. And then by the fourth year of medical school, you're supposed to have seen enough that you narrow down what you'd really like to do to 2 or 3 different possible areas of medicine, and then you take some electives in those areas, and then by the end of the fourth year of medical school, another set of board exams, so you have to pass those, And then you apply to residency. And residency is, I tell people, it's sort of like an apprenticeship. You know, in the old days, if you wanted to be a blacksmith, you studied under, you worked under a blacksmith, you learned the trade, right? And this is no different, really. Residency is where it's hands-on, taking care of patients, but you're supervised by staff, you know, by a full-fledged psychiatrist, let's say. And you do that for about 4 years. For psychiatry, it's 4 years. It's variable. Internal medicine, family practice, and pediatrics are about 3 years of residency. And then surgery, the different types of surgery are somewhere between 5 to 7 years. I think OBGYN now is 5 years. So it depends on, you know, which area you want to go into as to how long it takes. But for our purposes tonight, psychiatry was 4 years. So we did 4 years of college, 4 years of medical school, and then 4 years of residency. Now, believe it or not, you can still go further. If you want to specialize in some type of area of psychiatry, let's say geriatric psychiatry or child and adolescent psychiatry, and if you want to be board certified as a geriatric psychiatrist, you have to do 2 more years of what's called a fellowship, and then take another test. So after the 4 years of residency in psychiatry, you take the board exams, again, another set of exams. You pass those, you're board certified as a psychiatrist. But then if you go to 2 years of geriatric fellowship, you have another set of tests you take, and then you're a geriatric psychiatrist, board certified. Okay? What I've done is I did the 4 years, and then I stopped. I didn't do any extra specialization because I thought 12 extra years is plenty, and I'd like to get out there. I was 30, you know, at the time, and that's about on time, about what the age people would be if they did everything without, you know, having to go back and redo anything. So that, as you can tell, that's quite a bit of training. I mean, that's not, when somebody says they want you to be a real doctor, I mean, we're pretty much real doctors, and we're going through all the same stuff as all the other doctors, so we're real doctors. I think the problem comes in that psychiatry, we don't have a lot of tests that we can do, you know, scans we can do. It's not a hands-on profession. It's more abstract. I think other doctors and people have trouble with that sometimes. Now, people really get stumped by what's the difference between a psychiatrist and a psychologist. You ever thought about that? Psychiatrists can prescribe medications, exactly right. I mean, the way the psychologists are, and actually, it's funny you say that because there are now 2 states in the country where there are laws that a psychologist can take a few extra classes and prescribe medicines without going through medical school and all that other stuff. So that's kind of controversial. Psychiatrists and really a lot of psychologists are not too happy about that. But I mean, the issue was that there weren't enough psychiatrists. Somebody needed to do it, and so they decided they would push for these laws in these states, and they made it. So, but in general, you're absolutely right. In general, psychologists, the training is a little different too. So the psychologist goes through 4 years of college at least, you know, and then they do a graduate school. And graduate school it can be 5 to 7 years. And graduate school can be either a lot of research, you know, more research oriented, and you get a PhD out of that. So you're still a doctor, but it's not an MD, not a medical doctor. You're a PhD doctor, doctor of philosophy. And now on the other hand, there's also a psychologist. Psychologists can also go through graduate school and get what's called a PsyD. And a PsyD is more of a clinical degree. They're called doctors. I worked with one who was outstanding. She's going to actually do a talk for me, I think, in May, on eating disorders. So she's very good, but she can't prescribe medications. So she didn't go through medical school and learn all the physiology and all the pharmacology and all the stuff you got to have to prescribe, to know enough about medicines and everything and how they affect the body. So she's an expert at doing psychotherapy, talking to patients, and also some testing. Psychologists are really experts in testing. Testing would be things like IQ testing if somebody thought somebody had ADHD and you're trying to find out, or dementia. Sometimes we're not sure if somebody has dementia, so we'll have them go through, it's quite a lot of testing. It's about a half day. They'll sit down and they'll go through all these different areas that the brain, things that the brain does, and they'll test all of these things, visual, spatial, and all the memory and all this stuff. And so the psychologists are the experts at that. Psychiatrists are trained to do psychotherapy and medication management and really see the patient as a whole, but we're not really that good at testing. So that's one area that we're not so hot, and psychologists have us beat in that area. Not that it's a competition, but we each have our own expertise, and I guess that's one way to think about it. So in summary, a psychiatrist is a medical doctor that goes through, it's a real doctor, goes through medical school and is an expert at diagnosing and treating illnesses such as depression, major depression, bipolar disorder, schizophrenia, anxiety disorders, all these things. And they can use either psychotherapy and or medications to do so. Now, on a day, what does a psychiatrist do on a day-to-day basis? What are the different types of what are the different practice types, I guess, of a psychiatrist? I put this in here because I thought, actually know that some folks are going to be interested in maybe pursuing psychiatry. I've had some folks on YouTube who've said, hey, psychiatry looks pretty good, I'd like to do this. And so, and also somebody I work with, her son's interested in psychiatry, and I promised him I'd talk a little bit about what if you become a psychiatrist, what can you do? So, obviously you guys probably can imagine, private practice is one thing. So, you own a practice, you have office staff that work in the practice with you, and you see patients in a clinic, and you're in charge of all that as sort of the business person, but also the doctor. So that's one area that one thing a psychiatrist can do. There are a lot of places we can be employed. So where I used to work, I worked at a community mental health center, and a community mental health center it's basically a mental health treatment center. So there are you can go in and see the psychiatrist only. You can see the psychiatrist and a therapist to do psychotherapy, all in the same, usually in the same building, And there also are typically services for folks that have more chronic mental illness like schizophrenia, and they'll come in and they'll have day treatment where the folks will be in there during the day, and they'll learn different things to help them cope in their lives and things like that. And they also have group therapy and such. So the community mental health center, the one I worked at, I was employed by them, and took care of the folks that they needed me to see. And I actually liked the model that we had because in a few minutes I'm going to explain where I think somewhat the system is broken sometimes, in that the psychiatrist is doing medications for 10 or 15 minutes with a patient and is not doing any psychotherapy. And I don't know that that's the best thing in the world. And if you can't have that, which sometimes this day and age you can't, I think the next best thing was what I had in the model where I was working, where I would see the folks for medications, and then the psychotherapist would see them for psychotherapy, and I would meet with all the psychotherapists every week. We'd meet for an hour, and then usually more than that, where we would discuss cases and if there was any concerns or anything that was happening. So I would share how's it going with the medicine, how it was going with the medicine with the therapist, and the therapist would say, hey, she's dealing with this, this, and this in her life too, so be aware that that she may be getting a little worse even with the medicine and so on. I think that was very effective. It's not always like that, unfortunately. But so that's kind of the idea behind community mental health centers. Most towns have them. They can look a lot different depending on the town. So if it's a small town, they may be the only place that people go or can go for treatment. If it's a bigger city like Indianapolis, let's say, in an inner city like at Midtown, where I trained in residency, that's folks mostly that are indigent and have chronic mental illness. Okay. Some psychiatrists also you can also work in a correctional facility like a prison or something where you're seeing the inmates. You can also work in a state hospital for psychiatrically ill patients. State hospitals like Richmond State Hospital around here, and you guys have heard of Madison State and Central State, and all these. The state hospitals are places where folks that have more chronic illness that isn't really responding very well to the treatments that we have, or they can't, no matter, even if they get the best that they can get, they have trouble functioning on their own outside of the hospital, so they need a lot of support and a lot of structure. So psychiatrists can work in these state hospitals taking care of folks. You can work at a university. Basically, like I just said, you can train residents and medical students, do research, and also see patients at a university hospital. You can work at a pharmaceutical company like Eli Lilly or Merck or one of these places. If you're a psychiatrist, typically they'll hire you for some kind of neuroscience drug, some kind of drug that would be used in psychiatric illness. That job can take all different types of forms. I mean, you can do anything from designing the studies to show that these medicines are effective and safe in patients, to monitoring the safety of the medicines once they hit the market, after they've already been on the market for a while, just monitoring, making sure everything's going like it should. I should say too, you can divide psychiatrists into the different types. Like there's general adult psychiatry, and then there's geriatric psychiatry. There's a child and adolescent psychiatrist, forensics, which is a psychiatrist that evaluates people to see if they're sane, I guess, or they're competent to stand trial for some crime that they've committed. Obviously, a lot of times people, if they have a mental illness, if you have some kind of brain illness, it affects your behavior, affects how you look at the world and everything. And so sometimes you'll commit a crime when you're mentally ill, okay, when your illness is at its worst. And there are laws to protect people that do those things, and so you have to have a psychiatrist that would come in and evaluate those folks to see were they really, truly, psychiatrically ill at the time that they committed the crime, and that's a forensic psychiatrist. So there are all different types, and really the gist of this is, if anybody's interested in psychiatry, it's a great field to be in, because you can, there's not enough, first of all, so that means you can go anywhere you want to work. You can probably go anywhere you want to do residency and training as well. And then once you get out, the field's, it's wide open. You can do any type of psychiatry you want, any age group or anything. So, any questions up to this point about any of this stuff? Not so far. Okay. Another question is, that I get all the time, do psychiatrists really shrink heads? Are they really shrinks? I mean, not so much, really. I guess, what do you expect when you go to see a psychiatrist? That's really what we're getting at. I mean, people get so fearful of going to see a psychiatrist. I mean, every single person, after they get through seeing me, they're like, geez, I don't know what I'm scared of. But it's society. It's this big myth or something, a big stigma, But here's what you'd expect. I mean, it's really just like seeing your family doctor, okay? You call up to schedule an appointment. Usually somebody takes your insurance information, says, okay, well, your insurance is accepted here, we'll see you. And then you schedule an appointment. You go and you sit in a waiting room just like any other waiting room. Looks just like a family doctor's office. Usually the doctor's late, just about like any other doctor, okay? And all jokes aside, I mean, that's typically, usually, and not always, but usually that's because the doctor has a limited time with each patient and somebody's needed a little more time, and maybe if you're at the end of the day, a lot of people needed more time. By the time he gets to you, it's, he's running 2 hours behind or something. Well, hopefully not that far, but, half an hour behind or something like that. So, you wait to see him. Then you go in to see the psychiatrist, and during the first session, it's usually 30 minutes at least, and for me it was 60 to 90 minutes, or maybe even longer. I got kind of windy, as you can imagine, listening to me talk up here. But in that first session, the psychiatrist is going to try to get to know everything about the person that they can in that time. And that entails things like, not only things like, obviously the first question is, what brought you here? What's going on that brought you here? So then they'll ask all about the symptoms that the person's having, and they'll ask, how long they've been going on, all these things. Take as good a history as they can, because obviously in psychiatry, like I said, there's no brain scan, there's no blood test. I mean, it's all based on history. So we have to be very good at taking a good history. We get this, we call it a psych review of systems. It's basically reviewing all the different, have you ever been manic? Have you ever been psychotic? Have you ever had depression? Have you ever had anxiety? We ask all about the different kinds of anxiety, all these things. It's a lot of stuff. And we kind of narrow it down to what's really bothering them. And then we go into a medical history, which is just like your family doctor. Allergic to any medicines? Do you have any illnesses? I specifically always ask about head injuries. Seizures, head injuries and seizures I ask about, but surgeries also we ask about, other medications you take. Then we go into psychiatric history. You ever seen a psychiatrist? Have you ever attempted suicide? Have you ever been hospitalized for psychiatric reasons? And so on. A social history. Do you smoke? Do you drink? Have you ever used any drugs? All those things obviously can affect how you think, and how you present the symptoms you have. Even caffeine. I always ask people. I do a pretty good caffeine evaluation because at one point I had a patient come in with extreme anxiety, and I was taking the history, and if I hadn't asked, I wouldn't have known, but she said she drank a case of Mountain Dew a day. And I said, well, before we start any medicine, how about we just wean the caffeine a little bit? And, sure enough, she didn't need any medicine. So, you got to ask these things, okay? So, other things in social history, and I think some of this stuff people get uncomfortable about, and maybe this is where the head shrinking thing comes in, but we ask about childhood history and development history. So we ask about, have you ever been abused? Any sexual abuse, physical abuse, anything like that? Those things are very uncomfortable for people, but as you can imagine, they certainly affect how you develop and how you grow up and how you look at the world, And so if the psychiatrist doesn't know if that stuff is going on, it's kind of like he's blind. Whether she's got one eye patched or something. She's not seeing the whole picture. It's like if they don't know that stuff. Family history is incredibly important. That one's getting better, but in the old days, folks they didn't have names for these things. Well, mom laid in bed for 2 years, but we didn't know it was depression. We didn't call it depression. We didn't know what it was. We called it sleeping sickness or something. So the family history, you do the best you can. It's just not very reliable a lot of times. It's hard for folks to, you just tend to think, well, that was just mom, or that was just dad. That's just the way grandma was, And so you do the best you can with that, but sometimes you don't get as much as you'd like. We do tend to check, depending on the person, we'll check some memory, we'll check, we'll check different things in the brain, the functions of the brain, abstraction is one, so we'll give somebody a little proverb, let's say like, the rolling stone gathers no moss, and we'll ask them, what does that mean to you? With the ability of testing to see, can they abstract in their thinking, or are they very concrete? And if they're very concrete, they'll just say, well, the stone rolls down the hill and it won't gather moss because it's rolling down the hill. If they're abstract, they may be able to say something like, well, it means that the person that keeps on moving doesn't develop any kind of history or skeletons or any moss, so to speak. They keep on moving. So they're able to abstract. Don't cry over spilled milk is another one. So we'll ask some of those things. But other than that, I mean, at the end of the session, usually the psychiatrist, either they can tell you what they think is going on right away. It's pretty easy and they've diagnosed it right away. Or if they can't, sometimes I would tell folks, look, I got it narrowed down to 2 or 3 things, and the brain can have as many diseases as it pleases, so it could really be 3 things. But at this point, I'm not sure. Here's what I think it is. Here's the 3 things. I want you to look up some stuff about it, or here's a book to read about it, or talk to your family about it, or whatever, a pamphlet. And then the person goes away and thinks about it for a while, and then we eventually next session, maybe we come up with the idea of at least what we're going to focus on. But a lot of times we can tell just about after the first session what's going on, and we get some treatment started for the person. Usually then we have the person come back. If we're doing psychotherapy, which is a little more rare, we'll get into that in a second. It's a little more rare, but if we're doing psychotherapy or if you're seeing a psychotherapist, you know what that means, right? Psychotherapy, basically talk therapy, where you're talking to the person and you're making changes. I'll go into a second. For example, I'll give you some real life case in a second about what kind of thing you might do in psychotherapy. But it's the talking, not the medication part. And that is usually done every week to 2 weeks or so, especially in the beginning. The medication part, sometimes the medicines take a while to work, so the doctors will not maybe see you back for 3 weeks, 4 weeks, something like that. And so we're talking about seeing a psychiatrist, that's sort of in a clinic. But if it was in a hospital, let's say a person's in a psychiatric hospital, or even in a medical hospital, the psychiatrist would do all the same stuff the first time they see them, but they just probably would see them more often, so they might see them every day, especially in a psychiatric hospital. I would see my patients every day on the weekends when I was there. Really, no hocus pocus. I mean, there's nothing weird about that. At least I don't think there's anything weird. Does it seem like anything weird to you guys about that? I mean, it's just basically talking. As a patient, you just sit and talk to your doctor. You tell them your history. It doesn't seem like anything, earth-shattering to me, but I think that, again, it's misunderstanding. People don't know what's going to happen. I think they still think they're going to lay on a bed, and the psychiatrist is going to sit there at the head of the bed, not look at them, and do psychoanalysis. And I'm sure there are people that still do that sometimes these days, but not very often. There are still psychoanalysts, but I don't know too many that have the person lay down and do the old Freudian stuff. So,
what's the cognitive behavioral therapy?
Excellent question.
Well, it's different than what they used to do, right?
Yes. In psychoanalysis, let me go explain for everybody how that was done. I mean, it was much more passive on the psychotherapist part. So the patient would do all the talking, the psychotherapist would just listen, and every once in a while they'd interject something like, well, how did that make you feel? Or something, you hear that all the time. So they might do that, or they might, they pop in some observation, but very passive. They didn't do a whole lot of work in the session. It was mostly the patient doing the work. With cognitive behavioral therapy, again, still a lot of the patient doing the work, but it's very much a regimented type of therapy. So I guess the best way to explain it is to give you examples, maybe. That's the best way. Cognitive obviously means thought, and behavioral means behavior therapy. So it's basically changing your thoughts and your behaviors, with the idea that if you change your thoughts and behaviors, it'll change your mood or your anxiety. And they've done it now. They've shown it to be effective even in schizophrenia.
Yeah, but combined with medication for some mental
For
health.
anxiety, it is the treatment of choice. Yeah, if you have panic disorder, social phobia, generalized anxiety disorder, post-traumatic stress disorder, cognitive behavioral therapy with medication is the treatment of choice. I mean, hands down. The medication works in the short run, and the cognitive behavioral therapy works in the long run, and people that do the cognitive behavioral therapy and stick with it, they stay better longer.